Welcome to the March 2024 episode of Diabetes Care on Air, a fun way to bring the research in diabetes care to life. My name is Alice Cheng from the University of Toronto.
And I'm Mike Rickles from the University of Pennsylvania. We are your co-hosts for this podcast series.
As per usual, Mike and I will be interviewing authors of feature articles as selected by the editors of Diabetes Care, followed by our rapid exchange segment, where we give brief summaries of articles we found of particular interest.
But first, please remember that if you are not yet an ADA member, that the American Diabetes Association is offering a special deal, 25% off the annual membership cost for your first year when you sign up using the code NEW24.
And this offer ends March 31st. So I am sure you may be relieved this is the last time you're going to hear Mike and I bring it up. But we don't want you to miss out on all the benefits of being an ADA member that we have so much enjoyed.
So let's get started with the content for the March 2024 issue of Diabetes Care. In the March 2024 issue of Diabetes Care is a feature article entitled Disparities in Continuous Glucose Monitor Use Between Children with Type 1 Diabetes Living in Urban and Rural Areas. We have joining us the article's first author, Dr. Daniel Tilden. Dr. Tilden is an assistant professor of medicine in the Division of Endocrinology, Diabetes, and Clinical Genetics at the University of Kansas Medical Center in Kansas City, and completed this work with colleagues at Vanderbilt University in Nashville, Tennessee. Welcome, Daniel. I'm delighted that you could join us to discuss this important work.
Well, thanks so much for the invitation and chance to tell you more about what we've done.
Daniel, congratulations to you and your colleagues on this feature article. Prior work in childhood type 1 diabetes has identified lower socioeconomic status and racial and ethnic minority demographics as being barriers to care access, and that includes access for utilizing advanced diabetes technologies such as continuous glucose monitoring or CGM. Your article sought to understand the impact of geographic residence on CGM utilization in youth with type 1 diabetes. Can you take us through briefly how you designed your analysis to address this issue?
Yeah, absolutely. We previously used similar methods to look at changes in the demographics of who's being seen in our clinic as we transitioned to telemedicine at the start of COVID. So while that paper focused on disparities in patient visits by socioeconomic status and racial and ethnic background, we wondered if we could use similar methods to address other disparities we're seeing in the clinical care of our patients. As we thought about our population, it stood out to us that it was often our rural patients that had difficulty with multiple steps in the process of getting diabetes technology set up. So, between insurance and durable medical equipment hurdles, as well as issues with the technology itself and reliable internet connectivity, it seemed like this population often had more difficulty using the technology, which was becoming standard of care in patients with type 1 diabetes. Our hope with this study was to use similar analyses as we'd used in our previous study to address the question of geographic disparities in CGM use. So, our main hurdle in conducting the analysis was how we were going to most effectively measure CGM use. In looking at potential options to measure this, we were really drawn to using the CPT billing codes as our primary outcome measure of interest for a couple of reasons. First, we knew the timeline when clinician billing became mandatory within our practice. So that allowed us to define a clear time frame for the start and end of our analysis. And then second, we felt that the presence of CGM billing codes and the requirement of the review of at least 72 hours of CGM data to assign that code actually contained a significant amount of important clinical information within that one outcome measure. So as you know, when a clinician can bill for a CGM review, it means that the patient and clinic team were able to actually overcome a number of important technical hurdles, including getting the CGM set up, using the device for a meaningful period of time at home, and then getting the device downloaded into our system. And then the clinician was also able to use those data to impact patient care. And that's a lot of work that's needed to get to the point to be able to bill for a CGM interpretation. And each of those steps are also really important for CGMs to be as clinically impactful as possible.
Now, Daniel, your analysis found that children with type 1 diabetes living in small rural and isolated rural towns had a 31% and 49% respectively lower odds of completing a CGM billed clinic visit compared to those living in urban areas. And large rural towns, interestingly, had similar proportion as urban areas. Can you provide some context to these results and share your thinking about what factors may be driving this geographic disparity?
I think the key thing to understanding this analysis is how we define rural. So there are many different ways we can define rural versus urban. And among those are the rural urban commuting area codes or RUCA codes. And they're really helpful in not just defining what a place looks like, but in defining rural versus urban in terms of a variety of services and the services that are actually available to people who live in those areas, including access to medical care. So the RUCA code designations measure not only the rurality of the particular area, but also how much travel into or out of larger population areas with more services there are for any particular zone. So, for example, while two zip codes or census tract areas might have similar number of services within their boundaries, if one is 30 minutes from a larger town or city, while the other is 2 hours away, the lived experience of those in the farther away area is of decreased access. And therefore, those two areas are going to be assigned different RUCA codes, with the one with less access being classified as more isolated. So, compared to other methods such as measuring linear distances to clinics or resources present within a particular community, RUCA is actually a more nuanced picture of the impact of geography on the lived experience of residents. So the results of our study show that these more isolated areas had significantly lower odds of coming back to clinic, having sorted out all of those steps that we talked about earlier that are needed for the use of CGMs. Importantly, our study doesn't directly provide insight into the causes of these disparities. This is something that we're actually actively investigating right now. We're using qualitative and quantitative methods to try to get to the underlying cause of some of these things. So hopefully there'll be more to come from us here. But what I can say is that previous work suggests that long travel times, spotty or absent internet connectivity, and difficulty with access to transportation all likely contribute to decreased access to diabetes technology. For example, a patient having difficulty getting a CGM to work, if they live locally, might be able to schedule a nurse visit and come into clinic to get help, while a patient living in that more isolated area might have a multiple hour drive one way to get to clinic. And that isn't really feasible with tight work schedules or school obligations that might inhibit their ability to do that. So that patient, in my experience, the one living farther away, might decide to wait and go without technology until their next clinic visit to get their issue ironed out.
And it's so important to understand these barriers to access and implementation for CGM because, particularly in children with type 1 diabetes, it's been shown to have dramatic impact on improving glycemic control. And I want to highlight a more positive note of your analysis that indeed, while youth from small rural and remote rural towns are continuing to lag behind their peers living in large rural towns and urban centers for having that clinic visit with a coded CGM interpretation, these same more rural areas have shown the greatest increase in CGM use relative to where they were prior to the pandemic. So I'm wondering how you interpret this trend in light of the pandemic. So is there any reason to think that despite challenges with access to, say, internet, for example, in more rural areas, that somehow the availability of a telemedicine option that was spawned by the pandemic may have helped some of these children from smaller, more remote rural areas catch up with CGM implementation?
I do think it's true that telemedicine is likely a significant part of what's driving the uptick sort of later on in the pandemic period. But I also I also want to highlight that our data actually showed a slowing of CGM uptake in the early part of the pandemic in these most rural patients before those rates popped up. And to me, that really does demonstrate that this is a particularly vulnerable population who are vulnerable to disruptions in healthcare that we saw early in the pandemic. But I think you're right that they ultimately did benefit from the added flexibility in care delivery models by the end of the pandemic era. And I think that probably happened for two reasons. So, first, from the patient point of view, I think when we developed more flexible clinic models, we gave these patients more reliable and easy access to clinic resources. So, when no one was traveling to clinic, it made it easier to access regardless of geography. And that meant that getting questions answered and issues ironed out over the phone or on a telemedicine visit was more of a normal thing and made it easier for everyone, sort of leveled the playing field a little bit for everyone. And we had to do it for everyone because no one could easily make it into clinic. So our staff and providers developed those systems to help address those issues that previously had really only impacted a subset of our patients before the pandemic. I think the other side of it is really the provider side. And so I know from my clinical practice that a diabetes visit without glucose data is really rarely helpful in moving care forward. And so I think with our pivot to telemedicine and the need for that glycemic data to drive our decision making, I think we as providers became more acutely aware of those patients that weren't using CGMs and were more motivated to get CGMs in the hands of those patients and to push our clinic staff to really make sure that those patients were getting the care that they needed and that we were overcoming those barriers. So I do think that our increasing comfort with telemedicine and the constraints of seeing patients over telemedicine did contribute to the uptick. But I also think that the overall improvement in CGM technology over this period probably contributed as well. We saw improving reliability of CGMs themselves, and then improvements in the cloud data interfaces that we use, as well as improved insurance coverage across all payers, all of which, along with telemedicine, likely contributed to the uptick that we saw in this population.
And hopefully we continue to see those rates continue to climb. Now, another issue addressed in your article is how neighborhood deprivation affects CGM use among children with type 1 diabetes. And so I'm wondering if you can explain how this is assessed and how contributing factors to neighborhood deprivation may differ between those children living in more urban as compared to more rural communities.
Absolutely. So I think it's one of the most interesting findings of our paper. It's not sort of the top line, but I found it one of the most interesting. So the NDI, or the Neighborhood Deprivation Index, is a single measure that represents a composite of 13 different key variables that come out of the American Community Survey to assess the socioeconomic status of individuals living in a particular census tract. So, in contrast to the RUCA codes that we talked about earlier, the NDI is really looking only at the conditions within a particular census tract and not those external factors that are sort of factored in with the RUCA code. So when we used the NDI rather than the RUCA, we found that those with the areas of lowest socioeconomic status had the lowest rates of CGM billed visits, while those with the highest socioeconomic indicators had the highest rates of CGM billed visits. And the interesting part to me is that in some ways, the association with NDI was actually stronger than the association with RUCA codes. And that seems to suggest that while other dimensions of social determinants of health, such as race, ethnicity, and socioeconomic status, are important drivers of difference between populations, geographic place is also playing a significant role in these disparities. And ultimately, it seems that while the view out of the front door of a patient living in rural Kansas might be very different from someone living in more urban communities, the challenges to engaging with the healthcare system might be more similar than we expect. And both groups have similar barriers to reliable transportation and reliable internet connectivity. And they struggle with inflexible jobs and school schedules that make troubleshooting these technology barriers more difficult compared to those on the other end of the socioeconomic spectrum. And so, while I think there definitely are unique barriers to those living within urban communities and those in our more rural patients, I think they're more similar than we might expect, and some cross pollination of the ideas that we have to improve the access to care for those living in urban areas might actually help us understand better how to serve our patients in rural areas and vice versa. And so I think it's really a hopeful time for me that we can share some of that information and some of those learnings across different care communities to help everyone benefit from our insights.
That's really terrific and wonderful new insights that have come out of this work. And can you give us any final takeaway messages for addressing the rural disparities that are seen in diabetes care in general and in CGM use in particular?
Yeah, the main goal of the study was really to shine a bit more light onto the difficulty that our rural patients face in engaging with our care systems. Nearly 20% of Americans live in rural areas. So, if we want to continue to improve outcomes for all of our patients with diabetes, we need to be ensuring that we're addressing the particular needs of patients living in rural areas as we think about developing care systems to serve all patients, regardless of race, ethnicity, socioeconomic status, or geographic location. And I also want to highlight the ways that the lessons we learn from taking care of our rural patients can help inform the care of our patients from underserved backgrounds and vice versa. The patients really do face a similar set of challenges to engage in care. And I think that if we design systems and learn ways to better serve the broad diversity of our patient population, then we can make sure that care is accessible to everyone who needs it. And so, last, I just wanted to say thank you to you, Dr. Rickles, and my collaborators on this project. It's really been an honor to be able to talk to you today. And this paper really represents a true team effort. And I really appreciate the help and support of my collaborators and team here at KU and at Vanderbilt.
Dr. Daniel Tilden, I want to thank you so much for sharing your expertise with us today. I really appreciate all I've learned from your paper and our discussion, and hope that by considering patients' geography, we can really help advanced diabetes technologies reach an increasing proportion of children living with type 1 diabetes. I encourage the listeners to access the full article in the March issue of Diabetes Care.
One of the feature articles from the March 2024 issue of Diabetes Care is titled Waking Up to the Importance of Sleep in Type 2 Diabetes Management, a Narrative Review by Dr. Joseph Henson and colleagues from the University of Leicester in the United Kingdom. We are fortunate to be joined today by Dr. Joe Henson, Research Associate in the Leicester NIHR Biomedical Research Center, Dr. Andrew Hall, Consultant in Anesthesia, Intensive Care, and Sleep Orders Medicine, and the Senior Author, Professor Melanie Davies, Professor of Diabetes Medicine and Director of the Leicester NIHR Biomedical Research Center. Thank you all so much for joining me.
Thank you very much for having us, Alice.
To begin, congratulations to you and the team for authoring one of the chosen feature articles for this issue. As discussed in this beautifully written review, sleep is such a vital contributor to health, yet often overlooked by the medical community and by guidelines globally. However, the latest EASD ADA consensus statement broke that barrier and really elevated sleep and other health behaviors to the place it deserves. Can you start by telling us about the 5 S's from that consensus document, which I have to say I absolutely loved, which encapsulated the movement, behavior, composition over the whole 24-hour day?
Yeah, so thank you, Alice. And we're really excited to have this opportunity to talk more about the article. As you say, traditionally, the ADA ESD consensus has really focused on pharmacotherapy for the management of type 2 diabetes. And it's become increasingly obvious that 24-hour physical behaviors play a hugely important role in the management of type 2 diabetes. And so we came up with this concept of the 5 S's, which is quite a simple concept, but really encapsulates, I think, what we already know, but in a very graphical way. So firstly, stepping. We know that step count is important. People often talk about 10,000 steps a day, but yet in type 2 diabetes, we know that even if you can increase by 500 steps a day, that starts to impact on cardiovascular mortality. And a very simple message of 5 to 6 minutes of brisk walking can make a huge difference. The other important thing I think that's come increasingly from research is sitting. And so if we can reduce sedentary time independent of other physical activity behaviors, that can make a difference, particularly to metabolic health. So breaking your sitting every 30 minutes or so. The other important thing was sweating and strengthening. So sweating, we're talking about moderate to vigorous physical activity. And strengthening, increasingly, we know that people living with type 2 diabetes have accelerated aging and a poorer physical function. And so incorporating resistance exercise to start to tackle sarcopenia is really important. And also moderate to vigorous physical activity, the sweating behaviors also can impact on long-term health. And then the fifth S, which we're going to talk about a bit more, is this concept of sleep. So the whole 24-hour physical behaviors. And Andrew and Joe will talk to you a little bit more around these constructs that we talked about, which is the quantity, the quality, and the chronotype, which we highlighted in more detail in the recent narrative review.
That's fantastic. And when I listen to the 5 S's, I think they're so simple, yet so not done by, I would argue, all of us, including the people that we see. So I think very important messages. So let's narrow down onto the sleep aspect then. And you already mentioned the framework that was utilized, because we usually often just think about quantity of sleep, but it is so much more than that. So can you talk to us then about these constructs and what do they actually mean?
So yeah, I'll start with the quantity of sleep. So as you say, this is the one that people are probably most familiar with. And in terms of the recommendations, they're very broad actually. So people are suggested about at least 7 hours of sleep per night. And this is the same for those living with type 2 diabetes, the same as the general population. But in terms of the evidence, we know that there tends to be a U-shaped association. So when we look at those with short sleep, so typically defined as less than 6 hours, or long sleep, which is usually over 9 hours, these individuals tend to have up to a 50% increased risk of developing type 2 diabetes in the first instance. And we also know that every hour increase or decrease either side of the 7 hours recommended is associated with about a 10% increase in the risk of type 2 diabetes. And in those living with type 2 diabetes, we see a really similar association, so a U-shaped curve. When we look at things like HbA1c and fasting plasma glucose, they tend to be higher in short and longer sleepers. And actually, the strongest evidence appears to be in short sleep. And it may well be that those associations are causal in nature, because we know from some preliminary intervention work that actually encouraging people, or sleep extension, so encouraging people to sleep more, actually has beneficial impacts upon insulin sensitivity and reduces energy intake. So this is a real potential avenue for future interventions in those living with type 2 diabetes.
So not too much, not too little, I guess is kind of the message that I'm hearing here. Now, that addresses quantity of sleep. So let's now talk about quality of sleep.
So yeah, as I mentioned previously, there's probably a lot more to just the amount of hours that people spend in bed asleep. It's also the quality of that sleep that's important. And there's a lot of different things that can contribute to insufficient sleep quality. And that can impact health outcomes related to type 2 diabetes, but also they might have further overarching benefits or negative impacts on health outcomes, such as cognitive function or mood, for example. And we know that just focusing on the time that people spend asleep actually overlooks quite a few important areas. So, for example, the amount of time it takes people to fall asleep. So this is sleep latency. So people may be in bed but not be able to get to sleep for a while, but also the amount of time people spend awake after initial sleep onset. And we know that in people with type 2 diabetes, that tends to be a lot higher than the general population. So on average, that can be about an hour per night that's actually spent awake after they've initially gone to sleep. And then this obviously impacts upon overall sleep quality, and then impacts on measures of glycemic control, such as HbA1c.
So we've covered quantity of sleep as well as quality of sleep, but the third component of the construct that you discuss in the narrative review is around a chronotype and timing, which admittedly are not terms that I would have necessarily thought of per se. And then there's also this social jet lag, which I absolutely loved as I was reading about it. I know about regular jet lag from jets, but then what exactly is social jet lag? And tell us more about this chronotype and timing construct.
Yeah, social jet lag is an interesting title, really. And I think there's a danger that it may over glamorize the condition a little bit. I mean, are you too sociable? Are you leading a jet set lifestyle? Whereas the reality is it's basically a form of sleep deprivation. And unfortunately, for most people, occupationally related sleep deprivation is likely the biggest trigger. Essentially, we're all different in terms of when our bodies need to sleep. And that's chronotype, which basically the origins of the word just mean clock type. And whereas the average person may sleep from 11 till 7, there are going to be some early birds who like to turn in early and often get up early in the morning. And then there's the opposite, the night owls, the people who are often busy and active late into the evening and then really struggle to get up in the morning. And what we do know is that people that have a late chronotype have a higher instance of type 2 diabetes, but also obesity in general. In fact, a 2.5-fold increase in the odds ratio for these conditions. And that probably is because they spend much of their life fitting in with the educational, social, and working conformities of having to get up a little bit too early for themselves.
So in this case, knowing what type you are, I guess, would be helpful. And then seeing if we can somehow change society to fit the type that we are, maybe the other thing we could try to do, but I don't think that's necessarily possible. But that is very interesting because there's definitely people who are early birds and those who are, in fact, night owls. So now let's talk about proposed mechanisms, though, because I can't help but wonder what's chicken, what's egg, because maybe the associations that have been seen is just due to perhaps underlying disease states that then result in issues around quantity, quality, or this jet lag concept. So, what are your thoughts on proposed mechanisms for these associations?
I think you're absolutely right. And actually, there's quite a complicated association between sleep disorders and type 2 diabetes, and it's a bidirectional association. So, for example, we know that in people living with type 2 diabetes, the prevalence and incidence of sleep disorders such as obstructive sleep apnea, insomnia, and restless leg syndrome are considerably higher than those living without type 2 diabetes. And we also know from prospective cohort studies that the presence of sleep disorders is actually associated with an increased risk of type 2 diabetes and actually worse glycemic control in those living with type 2 diabetes. So there really is a bidirectional relationship there. In terms of more specific mechanisms, there's probably a few different or potential explanations as to why we see these associations. But we know broadly that short sleep is associated with several changes related to hormones, whether it be cortisol or melatonin, and inflammation that are known to impact insulin resistance and insulin secretion as well. And as Andrew alluded to previously, circadian misalignment also might play an important role in the sort of etiology of type 2 diabetes, because the circadian rhythm is driven by clock genes, and it's thought that changes in these clock genes are also associated with an increased risk of developing type 2 diabetes.
So, lots of interesting thoughts as to potential mechanisms, right, to explain these associations. This is likely not just an association, but very much likely to have an etiology aspect to it, I guess is the way to describe it. But let's now get practical. So you've convinced me that sleep deserves to be elevated and its level of importance is a modifiable risk factor that impacts multiple health outcomes. But what should we do better then as clinicians? What advice do you have for us?
Well, I think taking a bit of a sleep history is relatively easy and really doesn't take too long. Having a regular sleep pattern is important, but looking out for certain red flags. And people that struggle to get up in the mornings, that's certainly a red flag that they haven't had enough sleep, so they're struggling to get out of bed. People who are excessively tired in the daytime, and it's affecting their work, affecting their social life. People that fall asleep in meetings. And of course, the other big clue with sleep timing is having to catch up on your sleep on days off. So if at the weekend people feel they need to sleep in to catch up, that's a suggestion that on the preceding days in the week, they probably haven't been getting enough sleep. And then, of course, there are the disease-specific clues as well for sleep apnea, people who are evidently obese or perhaps have a more challenging-looking crowded airway, but also the history of loud snoring, audible from other rooms, disturbing bed partners, witnessed apneic episodes. And as for restless legs, well, of course, restless legs syndrome is a constellation of symptoms experienced in wakefulness, but it's associated with periodic limb movements in sleep. And that's the thing that does the damage to sleep quality, really. So symptoms of restless legs are relatively common and certainly should be asked about.
I think the other factor is that it's raising awareness, really. In the diabetes clinic, we often measure blood pressure, we look at HbA1c, but perhaps we need to be thinking about these very practical things that we could ask about. And in our narrative review, I think we've tried to give some examples, for example, of questionnaires and things that you could use to screen for some of these comorbid sleep disorders. But also things like activity measures, which we are increasingly measuring in the clinic. We can now look at duration of sleep. We can start to think about quality of sleep. And there's some very simple tips that we can give people to help quality of life. And it's one of the few modifiable things that we may be able to impact on in the diabetes clinic.
So I really want to thank all of you, Dr. Joe Henson, Dr. Andrew Hall, Professor Melanie Davies, for sharing your expertise with us today. I think you've certainly helped us to, as you said in the title, wake up to the importance of sleep in type 2 diabetes management. And I can't help but think of that expression, early to bed, early to rise, makes a man healthy, wealthy, and wise, which unknowingly, I think, captured the concepts of quantity and chronotype slash timing, but not necessarily quality, but I think it's probably implied within that old expression. So I strongly encourage our listeners to read the full review in the March issue of Diabetes Care to get those practical tips that were mentioned, not just for our patients, frankly, but for ourselves, because I think all of us can see things that we could improve in ourselves. And particularly, I want to give a shout out to the beautiful figures that have been created within that document to enhance learning and understanding. So thank you again to all of you. Let's move on now to our rapid exchange segment, where Mike and I chat about some of the articles we found particularly interesting this month. Mike, would you like to start us off?
Sure, Alice. My first pick is an article by Dr. Ran Cheng and colleagues from the University of Montreal in Quebec, Canada. They evaluated using higher thresholds than the currently recommended less than 70 milligrams per deciliter to treat non-serious insulin-induced hypoglycemia with carbohydrate in individuals with type 1 diabetes. So following a randomized crossover design, 29 individuals with type 1 diabetes received subcutaneous insulin in the fasted state and then took 16 grams of oral carbohydrate, either when their glucose was less than 70 or when it had just reached 80 or when it had just reached 90 milligrams per deciliter. And then they evaluated the resulting time spent in hypoglycemia, which was 26 minutes for waiting till 70, 18 minutes when treating at 80, and only 7 minutes when treating at 90 milligrams per deciliter. So each of these timing of interventions, there was no significant rebound hyperglycemia. And so we're already counseling our patients using continuous glucose monitors to treat downtrending glucose with carbohydrate before they get to 70 milligrams per deciliter and enter that range of hypoglycemia. And now these data support that such a recommendation with as much as 16 grams might be considered, I would argue, before you even get to 90 milligrams per deciliter.
Yeah, I would agree with you, Mike. This is certainly a recommendation we're already making. And the use of the trend arrows is so important, right? Knowing where you are, but knowing where you're going is obviously going to impact your decisions about treatment. And this particular study used a set dose of 16 grams of carbohydrate for every group, but some would recommend varying the dose of carbohydrate to treat impending hypoglycemia based on the trend arrows as well. So, all of this to say that, like most things in life, one size fits all, and firm thresholds to treat or not to treat are not appropriate for hypoglycemia, just like it's not necessarily appropriate for lots of other things. Now, my first pick for this month is a Danish nationwide register based cohort study by Dr. Maria Christensen and colleagues from the University of Southern Denmark that investigated the association between gestational diabetes, or GDM, and incident kidney disease. They included all women giving birth between 1997 and 2018, which totaled over 697,000 women. Median follow up was 11.9 years. They found that GDM was associated with higher risk of chronic kidney disease with an adjusted hazard ratio of 1.92. Subsequent development of diabetes and hypertension mediated this partially, but even in the absence of subsequent diabetes and hypertension, the increased CKD risk persisted. The CKD risk was higher among women with insulin treated GDM, even with no subsequent diabetes, compared to women without GDM. This, I think, is a good reminder that pregnancy is a window into both the metabolic and vascular future of women and should be treated accordingly.
And this independent risk for chronic kidney disease imparted by gestational diabetes is really eye-opening, and to me suggests the stress of hyperglycemia or insulin resistance on the kidney during pregnancy can have a long-lasting impact on renal function that's been previously underappreciated And I think identifying which factors are driving this association should really be a critical area for future investigation. My next pick relates to the identification of individuals at greatest risk for progression to clinical stage 3 type 1 diabetes. So who might now benefit from considering potentially disease-modifying therapy? Dr. John Verosco from the University of Texas at Austin and colleagues examined 65 individuals with preclinical type 1 diabetes, defined as having 2 or more autoantibodies, by measures of both pancreatic islet function derived from an oral glucose tolerance test, or OGTT, and pancreatic structure or size derived from magnetic resonance imaging, or MRI. They found that lower pancreas volume on MRI could predict progression to clinical stage 3 type 1 diabetes with similar discrimination as use of OGTT-derived measures, but that the structural and functional measures evaluated were themselves not correlated, suggesting they each represent different aspects of the underlying disease process. Importantly, combining the MRI and OGTT measures provided the highest accuracy for predicting progression to clinically symptomatic disease. So perhaps it's time to start thinking about evaluating both structure and function of the pancreas when considering risk for diabetes, as we do for other endocrine organs in clinical practice. And in fact, the authors point out that a non-contrast MRI sufficient for quantifying pancreas volume takes only 15 seconds to acquire.
And listening to you, Mike, it takes me back to medical school. And one of the first courses that we had in year one was actually called Structure and Function, really driving home the importance of thinking about both aspects in medicine. And the study that you just described, I think, sort of fits right into that concept. And although the MRI may only take 15 seconds to acquire, at least in Canada, one might need to wait 15 months to actually get the MRI, but that's a whole other conversation that we will not get into. The next one I'm going to discuss is a population-based cohort study using the UK Biobank that was conducted by Dr. Tian Fu and colleagues from Zhejiang University School of Medicine in Hangzhou, China. They looked at the link between type 2 diabetes and the risk of gastrointestinal disorders. Now, prior to reading this paper, I was fully aware of the association between type 2 diabetes and fatty liver disease, as well as pancreatitis, but apparently there are others. The study included over 370,000 participants who were free of gastrointestinal disorders at baseline, of which just over 19,000 had type 2 diabetes. During a median follow-up of 12 years, they looked at 15 different GI diseases. Compared to those who do not have diabetes, participants with type 2 diabetes were more likely to develop gastritis, duodenitis, peptic ulcer disease, diverticular disease, pancreatitis, metabolic dysfunction-associated steatotic liver disease, also known as MASLD, liver cirrhosis, biliary disease, as well as cancers of the GI tract, hepatobiliary cancers, and pancreatic cancer. So a fairly long list of GI disorders. Now, in the article, the authors review some potential mechanisms to explain the association, including insulin resistance, metabolic dysfunction, obesity, and in particular, visceral adiposity, as well as other mechanisms.
Well, I'm sensing a theme again in your picks, Alice. First, the association of gestational diabetes with future kidney disease, and now type 2 diabetes and future gastrointestinal disease. Because as the study points out, these individuals came in at baseline without having pre-existing gastrointestinal disease. And whether all of these are consequences of the diabetic state or share causes such as insulin resistance and hyperinsulinemia that may precede diabetes development really needs to be unraveled in order to inform future efforts at prevention. My last pick sort of fits with this theme, Alice, being about type 2 diabetes and cardiovascular disease. And this one came to me as a bit of a surprise, I think, given how long the study drug has been around. Dr. Francois Rubil from the University of Montpellier in France and colleagues conducted a randomized, double-blind, placebo-controlled trial to evaluate treatment with low-dose colchicine, 0.5 milligrams daily, in 4,000 745 individuals with recent myocardial infarction. And in the present report, provide the outcomes for a pre-specified analysis of the 959 individuals who also had type 2 diabetes. And what they found was colchicine reduced the risk for experiencing a future cardiovascular disease event by 35%, which is larger than the protective effect of 23% risk reduction reported in the primary study. And so these results highlight that the interaction between diabetes and inflammation is really important in affecting atherosclerotic cardiovascular disease, and the potentially greater importance to consider anti-inflammatory therapy in our patients with diabetes who have experienced recent myocardial infarction.
Yeah, an oldie but a goodie, right? I mean, we've had colchicine for a very long time. And I really look forward to seeing the results of the Colcott T2D study that is currently underway, looking at the effect of colchicine 0.5 milligrams daily and or non-enteric coated aspirin 40 milligrams twice a day for primary prevention of cardiovascular events in those with type 2 diabetes. Looks like 2026 is the expected completion date, so definitely something interesting that we should all watch out for. And speaking of cardiovascular disease and type 2 diabetes, my last pick is, to me, a sobering one. Dr. Richard Chowdhury from the Beth Israel Deaconess Medical Center in Boston, United States, and colleagues asked a very simple question. What is the level of awareness among people in middle and high income countries that diabetes is a major cardiovascular risk factor? This was an online survey conducted by the American Heart Association with nearly 50,000 respondents from 50 countries. Only 32.1% of the respondents were able to identify diabetes as a major CV risk factor, which means that 2 out of 3 people were not aware of this association. There were some differences based on age, with higher awareness amongst those 65 plus or from higher income countries. But bear in mind that the respondents were people who chose to participate in an online survey. And I'm one of those people that likes answering surveys, and we're a little bit weird, I have to admit. So people who like to answer surveys tend to be a little bit different. So they may arguably be an already more engaged group. So I can only imagine that among the masses, the knowledge and awareness is likely much lower, which is concerning given the rising global burden of both diabetes as well as cardiovascular disease.
Sobering indeed, Alice, and presents a real challenge for implementing strategies for primary cardiovascular disease event reduction. Even as you point out, there's new approaches being investigated, and being able to bring those approaches to bear in terms of reduction of events in this growing population of individuals with diabetes at risk for cardiovascular disease is certainly going to need to be a top priority going forward. And this brings us to the close of our March 2024 episode of Diabetes Care on Air. Don't forget, this is your last month to receive 25% off new membership dues for the ADA by using the discount code NEW24, that is NEW24, when you register online. This offer will expire March 31st, so don't miss out.
And remember that Diabetes Care, the journal, is continuing to take submissions of original art for consideration to be included on a future journal cover. Don't forget to subscribe to get notifications about new episodes, and thank you for listening.